So we'll discuss how to wean and how to taper from it, and we'll go for the evidence. The objective of my presentation would be weaning. I would like to discuss in that how to troubleshoot also, reviewing the complication in short and evidence for the use of the HFAV. I'll try to make it simpler for you. Next. So coming to the HFAV weaning. So we have to monitor once we have seen how to initiate the HFE of a baby. So this is the chart we are using at the unit for monitoring the data while baby is being on high frequency ventilator, recording of the time, map, FiO2, delta P, clinical parameter with ABG and X-ray as and when required after initial stabilization of the map, and what action we are taking. While going on, the troubleshooting is the important part as always. So we'll look into the small thing, what we should do. If we feel the sudden deterioration with the loss of chest wobbling or bouncing, what we should do? We should, as always, first the equipment failure has to be checked. Check ET2 positioning, patency, consider action, as we'll do all this thing in the conventional ventilator also. Is there any bad obstructed ET tube? Fixation is wrong, dislodgement is there, pneumothorax is there, or patient equipment asynchrony is there. Consider the manual ventilation through ET tube to assess the tube position, patency, and chest rise. This will do in any mode of the ventilation as usual. Now we have to set the delta P or a tidal volume, or minute ventilation is low. What we should do? We should check the ET tube position, do the suction as needed, consider the chest X-ray for lung inflation and the disease because we are not getting the minute ventilation. Consider a recruitment maneuver carefully. If on high map more than 14, consider the changing of IE ratio is to 1:1. Check the ABG meanwhile to synchronize your decision, and some baby may benefit from a change in the frequency also. Next. If the minute ventilation is high, see our alarm setting, what we have kept in the initially and how the ABGs go, whether we will need to the adjustment of the alarm setting, review the patient, assess the wobbling of the chest, assess the tidal volume, check ABG, and wean accordingly. Consider the volume targeted HFOV if your machine is permitting the same. Lack of improvement at the clinical parameters. See the ventilatory parameter. Consider increasing MAP 1 to 2 centimeter. Vigilant observation and monitoring bedside is essential. See our dope assessment. Consider the muscle relaxation if needed, and treat the hypotension if present. Some baby do not improve with the HFOV and may benefit switching to the conventional ventilation, as we sometimes see in clinical rounds. If baby is hypotensive, consider over distension. Can MAP be weaned? If baby is hypovolemic, consider the use of hypotension and need for the inotrope. So these are the few troubleshooting and thought-provoking points we should take into consideration. Next. Once after all this is a continuous process, but after all this, we have to start weaning. Once baby is stable, and oxygenation, typically FiO2 needs to be 0.4. It doesn't matter much when baby is clinically stable and you are able to come down on reasonable low FiO2. Weaning can be started. Each change should be closely monitored. How are the clinical parameters? What is the saturation? How is the heart rate and blood pressure? You have to fill in that monitoring chart. ABG should be performed around 20 to 60. Sometimes half an hour is a reasonable time depending on the magnitude of the change. MAP should be reduced gradually initially over the period of the time. Reduce one MAP at a time over 4 to 6 hours. Once you have come down to reasonably low MAP, then you can increase the rate of decreasing the MAP. Now, how to tighten the amplitude? If volume targeting is being used, the amplitude will auto wean as the lung mechanics improve. In the absence of volume targeting, amplitude can be weaned in the step of 1 to 2 centimeter of water every 4 hours, guided by your PCO2 or DCO2. Instead of the amplitude, power is also used to determine the volume of the gas driving oscillation. This can be weaned 0.2 to 3 every 4 hours. The target PCO2 will depend on the clinical situation. It will be higher when we are keeping the thing of permissive hypercapnia in the mind. Next. So now we have reached the reasonable setting of MAP of around 9 to 10 and FiO2 0.3 to 0.4. I want to re-emphasize FiO2 doesn't make much sense when the baby is systemically stable, disease is improving. So we can think of extubation. Some may, there are two thoughts of school. So some prefer the HFOV route, means they will come down on MAP and directly they will shift to the CPAP. Other will change from HFOV to CMV, conventional mechanical ventilation, and then extubate. No consensus guideline is available. Each unit has own have own protocol. So this is a choice basically. Next. Some do's and don'ts I want to discuss while baby is on being HFE. Avoid disconnection from the ventilator as much as possible during repositioning or change of the linen, as this causes the alveolar collapse and loss of lung volume. Perform ET suction very judiciously, otherwise baby would collapse immediately and it will take some time again to reach to the same parameter. Suction is to be done only if there is evidence of tube leak. Ensure proper humidification of the gas. Ensure that the tubics are not being dampened. Nurse should keep a vigilant watch over the level of wiggle, any change of the wiggle, humidification, last suction done, and the last desaturation. The monitoring include evaluation of the ventilatory setting and chest wiggle in addition to importer vital parameter. So basically we have to maintain our monitoring chart very up to date, and in case of the acute event, what actions are taken, that to be mentioned. Next. Now, potential complication, I think this has been discussed, but we'll go high MAP. So what will it will be in? Yeah. So high MAP will be lead to elevated intrathoracic pressure, will dampen the venous return and increase the intracranial pressure also, and the IVH, the PVL thing, as we'll see in further study material. Next. Low MAP will remain the atelectasis issue unresolved. The previous studies, like in 1980s and 1990, will show has shown increased incidence of PVL and IVH. At that time, the proper ventilation strategy for the HFOV was also not established. But the current systematic review and meta-analysis did not show any differences. Next. One other known complication is necrotizing tracheitis, linked to the tracheal inflammation and obstruction in various studies. All the method of the high frequency will lead more necrotizing tracheitis compared to CMV. Humidification, rate, FiO2 level, duration of the ventilation, and severity of the underlying illness affect the incidence. Next. Now, this is the, I think, a bit boring part for you. I'll try to wind up as early as possible. Next. So, there is a point of discussion whether elective or a rescue high frequency ventilation should be used. In this thing, over a dozen of randomized control trial of elective versus convention, elective versus the rescue, and elective versus CMV for the treatment of the neonate with respiratory insufficiency been performed, primarily in the babies with RDS of the prematurity. High frequency ventilation in the form of high frequency positive pressure ventilation, jet ventilation, or oscillatory ventilation were unable to demonstrate any significant difference in pulmonary outcome between babies treated with HFAV versus CMV. Few studies demonstrated a small yet significant reduction in BPD in the HFOV group. Next. This is the well-known Cochrane of 2015 by Cool et al. Next. The thing was they compared the elective high frequency oscillatory ventilation versus conventional ventilation. Their objective were they wanted to find the incidence of CLD, mortality, and other complication associated with prematurity and assisted ventilation in preterm baby who were ventilated for RDS. They were comparing the electively used HFOB versus conventional ventilation. So they search for the those RCTs. Next, what were the main result? Around 19 eligible studies they found, and around 4,096 infants were included. No evidence of effect on mortality at 28 to 30 days of age or at approximately term equivalent were found. This result were consistent across the studies and in subgroup analysis. The risk of CLD, those who survived at term equivalent gestation age, was significantly reduced with the use of HFO. But this result was inconsistent across the country. There was significant amount of heterogeneity amongst the studies. Pulmonary air leak occurred more frequently in HFOB, whereas the risk of severe ROP was significantly reduced in the HFOB group. No significant difference in the effect of IVH and PV well that thought to be more common in HFOV while considering the previous studies were found here. Next. So what they conclude in the simple language, evidence that the use of the elective HFOV compared with conventional ventilation result in a small reduction of the risk of the CLD. But evidence is not very much up to mark. Evidence is weakened by the inconsistency across this effect across the trial. The benefit could be encountered by the increased risk of acute air leak. The adverse effect on the short-term neurological outcome have been observed in some studies, but this also not significant overall and not consistent across the study. Most trials reporting long-term outcome have not identified any difference. Next. So these are the things. Here the confidence interval including one. This was the outcome for the death. Next, you can see the diamond shape crossing the line. These are for the CLD and at the term equivalent age. This favors HFOV. Next. So what was the issue here? A number of efforts they have been made to identify factors that may explain heterogeneity in this outcome in this particular Cochrane. They are across the 19 studies. In general, the optimal lung volume strategy, early use of HFOB less than 6 hours or around 6 hours, IE ratio 1:2, extubation to CPAP rather than a trial of CMP, lack of lung protective strategy in CMP were associated with the trial that demonstrated the reduction in the chronic lung disease in the HFOB group. Next. Now coming to the device, what they're finding, the piston oscillator are using that also associated with the better outcome, but it's impossible to disintegrate this characteristic from the other factor. How is our ventilatory strategy? But other study by other RCT and meta regression done by Bollen and colleagues, they were opposing this finding. The nature of the pressure and flow waveform that lungs are exposed to rather than the mechanism by which the waveform is produced is what ultimately matter that they mentioned in Bollen et al. Study. Next. So overall, looking by animal study and various preterm study and this 2015 Cochrane, what they concluded, grouped analysis of all RCTs to date would not support the selective use of early and elective HFOB over CMV in preterm baby with RDS. Although it remains a reasonable choice, the lack of the clear benefit of HFOB is very likely due to improved method. The period while we are using the HFOB thing and standardizing the ventilation across this method, the CMV ventilation strategy also improved. And that also included the volume targeted with convention also. So the elective as a first line HFOV use is limited. It's a particularly choice of the unit, not the recommendation. Now coming to the evidence of the safety of high frequency ventilation. The very first study, very old study, hi-fi study, showed that compared to early HFOV2, I know it's a bit boring, but I think we should take a crux of the thing. Uh, hi-fi study that compared the early HFOV to CMV, as HFOV treated group demonstrated increased incidence of IVL and PVL as well as the air leak also. And the neurodevelopmental follow of that study, extension of that study, 16 to 24 month PMA were significantly worse than HFOV study. But here is the breakthrough. No PCO2 data were established there. They have not mentioned it. And the alteration of the PCO2 could have led to this damage. That was the explained finding. Other studies, Curtini and et al. And Johnson and et al. Demonstrated no difference in IVH and PVL, nor did our previous pool 2015 Cochrane. Next. So HFOV is a good option safety-wise. Now coming to the data for the rescue HFOV. Use of the rescue HFV when the CMV appeared to be failing to do the adequate gas exchange or in a certain condition, what are the evidences and what we should do? That is our main thing. So 4 RCT in the premature and term infant are there. I'm not mentioning the list of the study, otherwise it would be too long thing. Have accessed the high frequency ventilation as a rescue technique after failing of the conventional ventilation. These data are very limited. Some are the earlier pre-surfactant study and some are the surfactant EDA study. Amongst it, 2 studies using the high frequency jet ventilation and 2 are using HFOV. So HIFO trial demonstrated the improved gas exchange and lower rate of the new air leak with HFOV. Here we are contradicting the previous finding. There were no effect on the existing air leak and no difference in the overall pulmonary outcome and marginally increase in the rate of severe IVH. Every study at every point, whether it would be a strategy, whether it would be a modality, either elective or rescue, when we are considering the meta-analysis, we are considering the multiple randomization studies and all that, the problem is heterogeneity is too high. There is no consistent data among the methodology of the mechanical ventilation, either be it a high frequency ventilation, be it a conventional ventilation. So the results are inconsistent all across the studies and Cochrane. Other or very known author Kaiser et al. Specifically enrolled the infant with PIV and showed improvement in PIV in jet ventilation high frequency compared to those remained on conventional mechanical ventilation. Next. Other 2 trials, they were done in old preterm baby. Amongst that 4 trials, 2 trials were been performed in older infant. What did they show? They show the notable improvement in gas exchange and treatment success in high frequency group. However, there is no significant difference in the incidence of BPD or death between those who rescued with HFV or those who remained on CMV. Meta-analysis of the rescue HFV versus CMV in Cochrane, this is another Cochrane, demonstrate that there is no clear long-term benefit of using rescue HFV or HFJV over continued mechanical ventilation. Next. So coming to other condition, this were basically the Cochrane and the multiple meta-analysis and RCTs were done in the preterm or late preterm babies with RDS. Now, what is the stand for high frequency ventilation in other condition? As we know in the previous lecture, various modalities for the ventilation using high frequency. So what is the general? I'm not going into the depth for each and everything the studies. I would like to mention the crux only. The persistent pulmonary hypertension secondary to meconium mass, meconium aspiration or other form of the lung disease often respond to INO best when HFOV is used for the support. Likely because of the improved lung aeration and consistent tidal volume and PEEP across the alveoli. What is the other condition? Post-surgical support. When other surgical modalities are there, omphalocele, gastrocysts, NEC, and other conditions that restrict the diaphragmatic excursion may benefit from high frequency oscillatory and jet ventilation as well. Infant with pulmonary hyperplasia of various etiology may benefit from the very small tidal volume generated by various form of HFI. What is the benefit? What we have seen in previous two lecture is small tidal volume, potentially reducing the risk of air leak and volume trauma. Next. So I'm coming, I think I'm reaching the end to the thing. This is the one study I want to mention: conventional mechanical ventilation versus high frequency oscillatory ventilation for congenital diaphragmatic hernia. What was the objective? Oxygen and ventilation damage resulting in a high, on what background they have performed? Oxygen and ventilation damage resulting in a high incidence of BPD and chronic respiratory morbidity. Here they have taken the 171 prenatally diagnosed CDH between 2008 and 2013. And what did they find? Around 53.2% patients initially received conventional ventilation, and around 46.8% received high frequency ventilation. And they concluded that no statistical difference in the combined outcome of mortality or BPD between two ventilatory groups in prenatally diagnosed CDH. Other outcomes, including shorter ventilation time, the lesser need of the ECMO, and all favors conventional ventilation. As of now, what we are using, we are not using HFOV as a primary mode of thing. We'll start with the conventional and then use HFOV. Next. So I want to say, still they are not using, still the data suggesting no use of elective, use as a rescue, and use in the other condition according to unit wise. HFV is still experiencing a resurgence in the first intention use in extremely low birth weight, not in the routine thing, 22 to 24 week of gestation. Because we more and more high risk obstetric centers are offering resuscitation to this tiny baby. The interest of the in the field of high frequency ventilatory support as a first line respiratory therapy is increasing. It remains to be seen if the approach leads to lead to less CLD and better outcome, because our ultimate respiratory parameter or outcome is CLD. Next thing will come the hospital stay and all that will come, but that in that also it is still, data is still lacking. The unit wise preference is still persisting. Now coming to the data for the high frequency nasal ventilation. So here also same. So many studies, so much of heterogeneity, more than 50% of the heterogeneity. These are the few trials who have been completed in recent years. These are the 5 trials. And see the gestation. Gestation wise also equality is not there. That Mukherjee et al. Is also including few extreme low birth baby. See the settings also, the map and all that is also, and frequency is also not very much consistent. Next. So what did they include ultimately? Consistent, they are not supporting the high frequency nasal ventilation as a routine standard care, because though it prefers, though it prevent the intubation in some study, though it improve the ventilation as compared to conventional ventilation, and though it provide the tidal volume across the all alveoli at the respiration cycle equally without variation in the pressure much, something to be better studied and clarified. Like comparison of the high frequency driver, which are the better one, which is to be used, determine the optimal frequency and optimal inspiratory time, but pertaining to that specific condition, the relative benefit and benefit of different interfaces, and what are the leaks to be considered normal, what are the leaks to be considered allowable and not allowable. The potential role, if any, if NIPPV will combine with that NIPPV positive pressure ventilation we have seen in the previous slide long back, that changed during the HFN, and ease of the use of the which interface is better one. Next. So I'm concluding this boring, I think very much, I don't know whether you have understood or not. Just I would end with this. High frequency ventilation is a unique and useful form of mechanical ventilation and is now a standard form of therapy for a wide variety of respiratory conditions, not all. Often produce the excellent gas exchange at lower airway pressure than our conventional ventilation. It allows safer application of high MER when necessary for lung volume recruitment and oxygenation, as we have seen the recruitment process, and coming back to the safe pressure for the optimal ventilation and oxygenation. It's superior to the conventional mechanical ventilation in air leak syndrome in multiple studies, though the heterogeneities are there, and may be useful. This is very important. May be useful as a rescue technique and or bridge to the ECMO. Before ECMO, it is worth to try HFOV. Its clear usefulness as a rescue or temporizing measure in the pulmonary, clearly usefulness is there in pulmonary hyperplasia, PPHN, meconium aspiration, and other form of neonatal respiratory failure when non-responsive to CMV. Next. Neonatal RDS, we have to see the long-term outcome. Though the CLD rates are showing no difference, but we have to see the long-term outcome when we are using the HFOV with the surfactant therapy. And volume targeted HFOV may provide even better therapy for neonatal respiratory disease. Various studies are there. Some are going on establishing the normal tidal volume for each condition, for each gestation age and weight, but no concession has been made till date. So this is it. Thank you. I would happy to take any question or any confusion if it's there.
So just to summarize for our residents that one thing that though it seems very good on paper, sometimes high frequency ventilation may not be the final thing. I mean, when we were in MD, we used to think कि अच्छा conventional ventilation पे नहीं आ रहा है कोई बात नहीं, high frequency पे रख दो उस पे तो आ ही जाएगा. Okay, so that may not be true for all. We have to understand the disease physiology. HFO definitely stands superior to conventional ventilation for recruitable lung diseases, but maybe for non-recruitable lung diseases or for heterogeneous lung diseases, it may not be very good. Second is that now we are in the era of evidence-based medicine. We are all practicing what is evidence, what is the evidence. So unfortunately, when it comes to high frequency ventilation, the evidence is not very good. Okay, all the enthusiasm which was there in the early 90s and late 1980s about high frequency ventilation was actually, to their surprise, not showing good results. But if we look at the evidence, so most of the studies which have been done, they were done in the pre-surfactant era. Okay, so that is one of the reasons, probable reasons why high frequency ventilation did not stand out superior to conventional ventilation. Now the things have changed. We have, one of the reasons is that we are more comfortable with conventional ventilation. We are not so comfortable with high frequency ventilation. Second is now we are using more surfactant. Third is the use of antenatal steroids has improved. So as such, the severity of lung injury in the antenatal period, in the initial few postnatal days has come down. So that may be all the reasons for which HFO has still not proven to be very much useful, though theoretically it stands to be very much useful. Second is in certain case-to-case scenarios, there may be situations where you are not going to get a response with conventional ventilation, but you get response with HFO. So I think with that, we can conclude if there are no questions.
Hello.
Yes.
Hello, Dr. Sandeep. This is Dr. Ankur Chaudhary from SMIMER Hospital.
Yes,
I am assistant professor in SMIMER.
sir.
Actually, you must have used that Sophie ventilator machine in SMIMER, in which we have HFO mode. But
Yes,
along with HFO, one more mode, HFO plus IMV.
Yes, yes.
is also there. So, can you briefly tell us when we should go with HFIMV, or can we straight away go with HFIMV from conventional, or can we use it as a weaning mode, or when we should ideally use that mode, HFIMV?
HFO with IMV, sir, actually it is, I mean, not a standard mode to say. There are certain ventilator companies who, along with the HFO, they will add option of sigh breath in between. Okay, that is
Yes, yes.
just to improve the, when you are ventilating on high frequency ventilation for a very long time, sometimes you are using so low tidal volumes that may be detrimental. So that is the explanation which they give to have sigh breaths in between. But I mean, if you search the literature, there is not much superiority of that mode as compared to the routine high frequency mode which we are using. So I mean,
Okay.
as such, I mean, we also have this SLE machine here, and we have that option of HFO with CMV. But practically speaking, it doesn't provide much of a benefit.
So we should go with that HFO standalone mode whenever
Yeah.
it is possible. So
Yes,
we should not go with HFIMV.
yes, maybe it will not help much. I mean, there is
Okay.
no such study or literature to.
Okay.
Uh, I mean, this is just a mode which many of the companies are providing, but I mean,
Okay.
there
Okay.
have not been many studies to prove it, or I mean, how superior it is. Nothing has
Okay.
been mentioned.
Okay. Okay. And we also had the dragger ventilators, in which HFO only standalone mode is not there, but HFO plus IMV mode is there. So
Yes.
it is not of a use, not of a much use, as you just mentioned. So we should not go with that HFO IMV unless and until we do not have any other choices.
Yeah, preferably. I mean, yeah, until and unless if it is a no option case, you may definitely
Yeah.
go with it. But if available, I think you should go to the conventional one. I mean, the routine HFO which we use.
Yeah. Yeah. Okay. Okay. Thank you so much. And I would say all three sessions were exceptionally well made, well presented, and all the speakers are really good. Thank you so much.
Thank you so much. So, I mean, since we are one is time was a constraint, and second is like it was more for MD residents. So we didn't. I mean, I specifically didn't discuss much about volume guarantee during high frequency ventilation. And second aspect which I didn't discuss at all was about the nasal high frequency ventilation. So these are the two things which have come up in the last few years, and they are there is initial evidence which shows that they are useful. Uh, we don't have ventilators at this point for volume guarantee as well as nasal high frequency. Maybe in future, if we get some, we'll have a session on that also. So I think with that we can conclude if there are no other questions. And someone has just put in the chat box wiggles up to the chest or to the lower abdomen. We usually target it up to the chest or upper abdomen, or maximum up to the umbilicus. Definitely not till the lower abdomen. It has to be up to the chest, and that too, it is just a crude marker. Sometimes, even if you are targeting your wiggles up to the chest, and if your CO2 washout is very high, you need to come down on your pressure amplitude. Okay, that is just the initial this thing. After that, you have to rely on ABGA and your DCO2 values to decide your this thing. Because see, as the compliance of the lung improves, your pressure amplitude requirement will definitely come down. So if you keep the baby on one single pressure amplitude, eventually as the disease improves, your CO2 washout will happen and the child may worsen. So I mean, it has to keep on changing as per the CO2 levels, as per the respiratory mechanics. To start with, you target it up to the chest or to the lower upper abdomen. Sorry. Yeah. So if there are no questions, I think we'll stop. Thank you so much, ma'am, and Abhijit sir, for joining.
Thank
And
you
it was
so much for the opportunity. Thank you so much.
yeah, it was pleasure to have you both. Yes.